When it comes to cardiovascular care on the organizational level, MedAxiom, an ACC company, understands the challenges your program is facing. Welcome to MedAxiom HeartTalk, the podcast where thought leaders come together for one ultimate goal: to continually transform and optimize cardiovascular care for all. MedAxiom HeartTalk starts now.
This is Cheryl Toth, host of MedAxiom HeartTalk, and this is our weekly COVID-19 briefing. As the CV services community deals with the pandemic in real time, we continue to bring you answers and insights from physicians and administrators on the front lines. We also continue to expand our COVID-19 resource page at medaxiom.com/COVID-19. You'll find coding and telehealth guidance, legal and advocacy updates, clinical guidance, and all of our COVID-19 webinar recordings. Our guests for today's weekly COVID-19 briefing are nationally recognized leaders who've been at the forefront of guiding programs and members through the COVID-19 crisis. Calling in from Kingsport, Tennessee, is cardiologist and physician executive Dr. Jerry Blackwell, president of MedAxiom. And joining us from Woodbridge, Illinois, in the Chicago area, is Cathie Biga, president and CEO of Cardiovascular Management of Illinois. Cathie is a board member of MedAxiom and the American College of Cardiology's Board of Trustees. Cathie and Jerry, we're glad to have you both back once again. Welcome to MedAxiom HeartTalk.
Thrilled to be here. Thanks.
Thank you.
So as we settle into whatever the new normal means, and national conversations move toward reopening, we're going to kind of kick things off with the issues that have been most concerning for you this week. And Cathie, I thought we'd start with you right there on the front lines in Chicago area. What's going on there?
Well, I'll tell you, when we had our last podcast, I was hoping by the time we rolled around to April 24th, I'd have thumbs up and good news for all of our colleagues out there. Chicago is really struggling. We have not hit our peak yet. We just got our stay-at-home order in through the end of May, and we're now on mandatory masks. So as you can imagine, it's testing all of us. But that being said, also I think the pace of change hitting our practices and our CV service lines it just remains unprecedented. I keep thinking our plates can't get much fuller, but why don't we leap right off and start talking about some of the legal things that have come down from Capitol Hill this week. Is that a good idea, Dr. Blackwell?
Yeah, I think that's exactly what we should do, Cathie. It's to me that has dominated what's going on. So let's jump in.
Yeah, because I really did think emergence, as we sort of call it, would be our hot topic. And I think we'll get to emergence towards the end of our podcast. But let's talk about what we are seeing from Congress, because it continues to evolve in our economic stimulus component. And of course, understanding that our hospitals are at the front line. So there is a new act that the House passed yesterday. As you probably know, the Senate passed it back on Tuesday. Many of us believe it's an extension, really, of the CARES Act. So it doesn't have its acronym yet. It's very long. It's called the Payroll or Paycheck Protection Program and Healthcare Enhancement Act. So there you go. It's a multi-billion-dollar component, mainly for small businesses and healthcare. So let's go through that a little bit as it relates in several areas. I think the first area is in small business loans. Many of our private practice physicians out there know that the first part of that $30 billion stimulus money was released. Most of you have seen it. Most of you also know that in order to accept that money, there is an attestation requirement to it. So probably one of the things, Jerry, we want to highlight today is just be careful with those attestation components as you are accepting both this original $30 billion as well as what we'll talk about in just a second. Part of the act is supposedly going to help mediate some of those components of the attestation. I have not seen as of today those new attestation requirements, but please check back to the MedAxiom COVID Hub as well as our listserv, always our fountain of information, before you do the attestation. But let's talk about the $20 million that was just recently released, because I think that is going to be significantly different for our practices and our service lines out there. That $20 billion, whether you're employed or you're independent, is going to be focused differently. It's going to be focused in the COVID hotspots. It's going to be focused on those individuals that provide less Medicare. The prior one was a little bit more based on your Medicare receipts. This one actually goes into that private payer. It's actually the 2018 total patient revenue. So many people ask, how do they figure out how much money to give us? That is one of the ways of looking at the 2018 components. So that's how that money will be distributed. We haven't heard when it will hit. Of course, watch the listserv. It was the first one that popped out as to when that was going to come. But Jerry, let's just stay on the stimulus money for a second, because what we're hearing from our employed physicians, especially those that may not be in any kind of payroll protection plan with their systems, and they're very concerned that they don't have any access to these dollars. Have you heard that amongst your colleagues?
Yeah, thanks, Cathie. So the answer is yes, but as you know, there are some, folks need to be very careful to be sure that they do qualify, because it is a very inclusive program, and particularly the stuff that is coming up now, where many of the funds have been are being released to smaller banks, smaller locations, and credit union type things. But no, it's a real problem, as you highlight.
Yeah, so I guess we can leave you with that stimulus money. Know that it is coming. Be careful with it. And if you have any questions, reach out to us. Your hospitals will also be getting additional money as part of that, both the $30 billion and this most recently released $20 billion component. And that is the original CARES Act. So don't confuse that with the bill, in case I might have confused you. Don't confuse that with the bill that was recently passed. Be careful with it. As Jerry mentioned, I don't have an answer for you on those dollars. If you're employed, if you're on a PSA agreement, if that billing tin is your systems tin, that's who will get the money. So we do encourage you all. Obviously, our front line is taking care of our patients and getting through this pandemic that we're in. But really, I think you should be at the table as physician leaders talking to your systems on how to adjudicate some of the that are in work RVU elements that have got zero payroll protection at the moment. So now let's turn our attention to this recently enacted law that we should have more information on, and perhaps we'll be able to cover some of those highlights in our Tuesday webcast that Cheryl will tell us about at the end. We hope to find some of the answers in that bill as it relates to phone visits, as it relates to payroll protection components, what requirements are going to be around that $484 billion that was just released. It just boggles my mind as we talk about these billions and trillions of dollars that are trying to keep our economy afloat during this crisis. But suffice it to say that that probably is the biggest thing that's come out of Washington. So Cheryl, maybe we should turn our attention to some of the other hot issues that we're talking about. Do you think there's any other questions maybe on the legal end that I forgot, either Cheryl or Jerry?
So, Cathie, let me jump in and just spend another moment about the Paycheck Protection Program and encourage anybody that's still eligible or considering this, go ahead and get off this podcast now and start going through that, because unfortunately the monies related to, or not unfortunately, just factually, the monies related to that are literally first come, first serve. And I will say there does seem to be some advantages to those who have banking relationships, particularly, interestingly, in smaller venues. Sometimes you can do better, but the overall application is relatively straightforward for those of you that haven't had a chance to look at it. There are some complexities to it, but I would encourage folks to do that. Cathie, I've forgotten the exact time that those monies were exhausted the last time, but this tranche is expected to subscribe, to be oversubscribed as well. And I will say that the answers to these questions from the banks, it's an interesting game, if you will, that you apply, and your answers should be known to you within literally hours most of the time. So I'll pause there. Cathie, do you have any other personal experience with that, or with folks that you've been helping with this, Cath?
Well, the reality is, as many of you know me, I am a small business owner. Our business, Cardiovascular Management of Illinois, we have not applied for a loan specifically because our partners have been, very good to us. I have kind of gone through the elements of what's included in that. And part of the big issue, one of the big issues we decided not to do anything was the limits to the forgiveness. What is a loan and what will be forgiven is still pretty murky. And I think that's the issue that most of our colleagues out there are sort of dealing with. Same with the advance payment. Some of you may have taken advantage of the advance payments from Medicare. And how is that really going to look? Because it's sort of easy in the height of the crisis to say, okay, here's all these funnels of money, give me the money, but what are the strings tied to it? And where is that going to leave our practices in August, September, October, as we sort of sort all this out? So I think that's, 2 points, Jer, we could end this with. Number one is if you want the money, if you need the money from either the small business loans or the payroll protection, you must do the application very quickly. You must align with your bank quickly, because we do believe that this money, although you think billions of dollars would go, there's a lot of small businesses. America is built on small businesses, so please act quickly. And then the second is for the stimulus money, please understand what you're accepting, and please understand what's currently in those attestations and reach out, because we do have that 30-day time frame for that. So I think we're in maybe about day 7. Which is why most of us have not accepted any of that money yet while we sort of sort that through. I think that's probably the best thing to leave with our colleagues on this topic.
Yeah, Cathie, I couldn't agree more. This does clearly fall into a topic that you need to get help with. You need to talk with folks that you have confidence and trust with, because the last thing we want to do is to encourage folks to go down a path that has a day of reckoning a few months down the road that none of us know about. The payroll protection program, Paycheck protection program, is likely to be safer because of what you're attesting to there. But even then, none of us know for sure, and hopefully that turns out to not be a loan, but actual money to as a bridge. But you do have to be careful. This is going to be very similar to IRS regulations, where one person's opinion can vary from another person's opinion. So just be careful about your documentation, how you're going into it, and I think it's fair to say that assume nothing's free. We hope some of it will be, but assume nothing is.
So get some assistance,
exactly
do
right.
things quickly, and this is a real priority right now because time is of the essence for applying for these things, correct? That's the best takeaway there. And so what are some of the other challenges that you all are seeing this week that our folks should be aware of, and especially the ones that are timely like this one?
Yeah, it was related to what we just talked about. Literally today. I mean, so there's no hyperbole there if you're in a highly competitive environment. But for most of it, obviously, we have a little bit more time. But there are just many different aspects of the legal component. We actually did a webinar that you guys can access from the MedAxiom COVID Hub. With Hancock Daniels from Richmond, very informative. It was actually phase 2, and I will say though that as it progressed, and literally things were, bills were being passed as the webinar was going on. You're just struck by what Cathie had mentioned before, and that is these rules remain very, very vague. So you need to deputize somebody in your organization or pay somebody to stay abreast of this, because this is not something that the average administrator trying to do their other work can keep track of, or the average clinician trying to do this off the side of the desk. That's just not going to work. But I will say, I'll transition. I'll get Cathie's, give all of your alls, but Cathie's reaction to that. But I say the biggest topic by a very wide margin is our reemergence strategies for folks. So I'll pause right there and get Cathie's reaction.
Well, I think that's true. But before we hit our reemergence, let's do another top issue. So many of you are trying to bill your telehealth visits, and you're trying to get paid for them. That continues to be relatively murky. So just as a quick update, and we will probably cover some of this also on our Tuesday webcast, know that the use of modifiers continues to be extraordinarily complex. There's nothing simple about it. We don't really encourage people to continue to hold some of these bills forever, but you are going to have to balance off the rapidly changing world with how you bill your telehealth. Let me just give you a couple that you might want to pay attention to, because as you know, when COVID first started, many of the payers are waiving copays and deductibles. That always sounds really good when we get that in an alert, but now how are these payers going to know that these patients might have been COVID patients? And for us right now, I would say it's mostly our hospitalized patients, although we are now, when we talk about our emergent strategy, we are starting to look at our COVID positive patients coming back into the office. So I'll just give you an example, like Cigna is requesting a modifier CS, that's Charlie Sam, on any visit that's related to COVID, assuming that your physicians have been very smart and are using the COVID ICD-10 code so that they know to waive those copays and deductibles for our patients. We happen to have NGS as our Medicare carrier. They also are requiring a modifier. I won't tell you it because I won't confuse all the rest of you that have got a different Medicare carrier. But as Jerry said, please, in our telehealth world, make sure that you have deputized somebody to watch all of those payers. We now do a 3-day-a-week payer update grid with all of the changes. So that may help. And the other thing, Jerry, I think we want to mention as we evolve into our emergent topic today is this pandemic threat of our patients not calling 911. The fact that we have so many of our cardiovascular patients delaying their STEMI care. I know MedAxiom has done some surveys around this. Are you still hearing it? Because we're still seeing it in the field, just a dramatic drop in STEMIs as well as other cardiovascular disease entities. And I think we need to get that word out to our patients, much like ACC has done with their recent campaign. Make sure that's on all of our websites for our service lines and our practices. I think that would help, don't you, Jer?
Yeah, Kath, couldn't agree more. So on all aspects of that. So as it relates to the coding and your term, Cathie, of a grid, I think is most important, which, by the way, again, you can go to our COVID hub inside of MedAxiom, and Nicole Knight, who's just done a fantastic job, along with Ginger Biesbrock, the rest of our team, and Kim Kaler from marketing, to have again, living, breathing document that can help with some of that. But this is something where it's crucial to the vitality of the organizations to do that. So I want to transition into your comment about the acute care, the STEMIs, et cetera. It's a very, very significant clinical concern, folks. There is, like many other things that we'll talk about, a regional component to it. It's just a head scratcher why you'd see a fairly significant decline in STEMIs. And the only thing that seems to make sense is that folks are staying away, period, where there's no good reason to think that there's fewer STEMIs. So we have to get the word out, and it is a paradoxical position we find ourselves in, encouraging folks to come for these acute things while being hyper vigilant for smaller issues. It's a fine needle we're trying to thread here, but I think that like so many things, the pendulum swung too far the other way, and folks whose truly their lives or health and well-being, long-term well-being, hinge on timely care are staying away from institutions. I think it's even magnified in urban settings versus rural settings.
Yeah, I think that's so true. And as we talk about our emergence or reemergence, and I think we will have several reemergence as COVID goes through several cycles until we actually have a vaccine for it. Based on what you just said, Jerry, I think that is so true on how you're going to design your emergent strategy. Hopefully our webcast on Tuesday will help all of you do that, because what is going to work for me in Chicago is not going to work in Kingsport, Tennessee, and is probably not going to work in Anchorage, Alaska. But I think if we can give everybody a framework on how to deal with it, as we talk to our colleagues, because none of us are experts in how we're going to design this reemergence, perhaps we can leave our crew with maybe 3 main thoughts on how you might want to design your strategy, and then tune in for hopefully some highlights on Tuesday. What is COVID like in your region? What's the prevalence? What's the incidence? You should be able to look at it by zip code. How safe are your patients coming out? So COVID awareness, we think, is the number one thing that you need to do as you plan your reemergence. And then the second area that you need to look at is patient safety, patient and staff safety. So what does that mean? How do you do social distancing? What does that mean for your waiting rooms? How do you slowly begin to open your practice where you're safe? What kind of testing is your recommendation? What is your PPE requirements, knowing that both testing and PPE are on the top list of every one of our discussions. There's some things on the listserv today. Illinois is in a total mask requirement, and yet trying to get masks is near high to impossible. So how do we possibly make our offices safe for our patients? And of course, what do we do with our COVID positive patients? It would be easy to say, we can't see you unless you have a negative test. Okay, where are they going to get that negative test? It's almost impossible to do. So I think the emergence will be an excellent topic for us to kind of peel apart. And hopefully you all will agree to us from both a podcast perspective and a webcast perspective that we can continue to help each other as we do emerge from this pandemic. What are your thoughts on emergence, Jerry?
Yes, thanks, Cathie. You really, I'm going to amplify the thing you commented on about the regional nature of this. My discussions with folks have really gone like this. The shutdown, in many ways, sounds silly here, but the shutdown in many ways was simple, right? You just shut it out, you turn the light switch off. Everybody can understand that. The social distancing, the shelter at home, those sorts of things, oddly, through the retrospectoscope, are as easy as can be. Coming out the other end is completely different because, as Cathie said, if you were in Washington State to begin with, New York, New Jersey, metropolitan, Chicago, Detroit, all the usual suspects, New Orleans, et cetera, you've seen something very different than the rest of the country. I've told the story that in my region, we not long ago had one COVID death, but 1,300 employees laid off from our healthcare system. So the economic carnage in some ways was more dramatic. And the point being that for those that have been in, and that's Cathie's comment about zip codes, those that have been in areas that have been less affected, they're going to want to reemerge from this cocoon much more rapidly than folks that are still maybe not in the eye of the storm, but still in the danger zone. So what we're focusing on inside of MedAxiom as we start looking through this is two separate ways to consider this. One is just a framework, coming up with a framework about how to do this, and the other is the notion of checklists. So we actually hope, if we can get this pulled off, and it's easier to talk about than it is to do, we hope to have, again, a living, breathing online tool. We even envision it with a slider, if you will, from completely closed at 0 to wide open at 100, and sort of help folks to they can enter where they are in the process. In other words, whether they're completely shut down or closer to being able to get back quickly. And based on where you are, have this living, breathing document that can help with the processes that we've found useful from around the country. In addition, we'll have some documents in publication, but almost by definition, they're going to be stale by the time they reach folks. And the final comment I'll make about that is, and you've heard me say this many times before, nobody's got the answer to this one. This is one where the shelter of each other, the intimacy of the network matters, because something will change in Omaha that should dramatically affect a lesson learned to folks in Illinois and on and on. So we're going to need iterative processes for these.
And from a practical standpoint, Cathie, how do you see, you mentioned the three things: COVID awareness, the patient safety. I mean, there's all kinds of issues around that, as you mentioned, and the issue around testing. In your organization, do you have a team of folks working on that? How do you think members should go about putting all these things together, given all the fast-moving information, but then really setting up some guidelines and rules and making it happen?
Yeah. So we did design. Remember, we're a large system, so I'll try to make this work for anybody. But we have a governance body at each location. Remember, we're 13 acute care hospital systems, but cardiology has their own emergent team that worked, and we separated our work into non-invasive imaging and clinic, and then our procedures and such, EP, cath lab, EVARs, TAVRs, all those types of things that have been totally on hold. Because remember, our patients have been out there now with 6 to 8 weeks of not being seen and developing problems. Last I heard, we didn't cure coronary vascular disease just because we have COVID. So I think the first thing, if you leave the podcast with anything today, get a governing committee together that's both clinical and administrative in nature, and use those 3 big buckets: COVID awareness, preparedness, and patient safety, and start to design your plan. And that way, as Jerry said, you can go from 0 to 60, depending on that very first bucket. Where's your COVID awareness? And where are your patients? Some patients have become very safe, cocooned in their little world. So I think it's important. And that's always, as you all know, from being employed and integrated all the way to COVID, having a governing body is, in my opinion, the most critical place to start. So that's what I'd recommend.
Jerry, you have anything to add to that on the governance side in particular?
No.
Colleagues.
Yeah, thanks, Cheryl. Great question. I completely agree with Cathie on this. This is one you got to have multiple folks involved. There is no single person that's capable of assimilating this and having the expertise for all parts of it. So it really does take a committee of folks, and a committee of folks that are committed to the up-to-the-minute scholarship on the topics, because it really is. I don't have a good parallel for the rapidity with which things meaningfully change, as has happened with this COVID-19 pandemic. Now, maybe there's been some others, and I'm always hesitant to use extremes here. But Cathie, I appreciate your thoughts. We've both been doing this a little while. I can't think of a reasonable analogy for the rapidity with which meaningful changes occur.
No, and we, to your point of a committee, what we have decided in our organization is what we have accomplished in 6 weeks would have normally taken us 16 years to figure out. Silos have been pushed down. I'll use our new anticoagulation policy as an example of that. And I know there was just recently published something on hyper-coagulopathy and COVID and these issues. And it took a village. It takes a village to do these things, to design a plan. We've got, cardiology pushing for higher anticoagulation rates. We've got hematology saying, whoa, wait a second. We have ID going, I don't know what this disease is doing to us. We have our pulmonary and intensive care individuals, and we just pulled the entire village into a committee together to come out with a very different looking product than we've ever had before, because COVID is an amazing animal and it has no bounds. It doesn't know any boundaries. So we had 2 20-year-olds that just came in the last 48 hours with these kind of massive, one had a massive PE, one had a DVT. I mean, it just is exhibiting itself in strange ways. And we need to react to that quickly. So command center governance, I don't want to go down a rabbit hole, but I did think just mentioning our anticoagulation component in light of the recent Jack article is something for all of us to look at, to understand that this is the time for the House of Medicine to come together to try to treat these patients until we get a vaccine out there.
Yeah, and as we kind of close on this reemergence strategy stuff, I just want to remind folks that this webinar next week, you will go into, it's a panel discussion. Jerry, you're one of the moderators, and Cathie, you're one of the panelists, and it's going to be Tuesday, April 28th at 5 p.m. Eastern, Managing CV Care Reemergence, beginning to prepare for post-COVID-19 patient care needs. That's part 1, so there's going to be a part 2 also. And folks, there's so much to say. Register at medaxiom.com/COVID-19. And then there are 6 other of the on-demand recordings there as well in that resource page. So why don't we move toward the exit here and talk about your stories of the week. We like to close on this to hear from our guests a specific innovation that you've used or witnessed, or just some example of an outstanding leadership that you've seen in the past week. And Jerry, let's start with you. What's your story of the week?
Well, thanks again, Cheryl. There's so many. I wish you'd quit saying the story of the week, because it makes me choose. But let me start with one that's fairly simple, but meaningful to me. And this is a personal experience in our region with a cardiologist. And again, as I mentioned, our region has been just unscathed compared to Cathie and to others. But we have all of the concerns, and we have our COVID units, and we have, a certain percentage of patients, et cetera, on this. But as part of this strategy, lots of discussion about whether or not the folks that are a little older in the group, and everybody understands the demographics of the age of cardiologists, but coming up with strategies to protect the folks in the group that are a little bit older. And we got fairly far along, and folks said, yeah, we got a couple that are in the sort of 65 range, et cetera, going to keep them out of the wards and out of the most critical care. And really, one of the most senior folks sort of chimed in and said, I appreciate all this, but the fact of the matter is I'm getting close to 70. Cardiology's been my life. I've served this region. I love what I do. It's a chosen profession. And you couldn't keep me from this. I'm saying his words. You couldn't keep me from doing this under any circumstance. This is what I signed up to do, and I am going to do it to the best of my ability. And even further, if something happens, smile. This is what I wanted to do. And those sorts of stories, when you understand the personalities behind them, what actually happens. And again, we're still we're not at the same level that Cathie is, but we have some of this that's coming. Those sorts of things are just so inspiring to those of us that are in this profession. That's the way it ought to be. So I'll stop there. I've got several other examples, but I'll stop with that.
And Cathie, how about you? I love that story. That's just great. It just shows the dedication. I mean, for those of us who are non-clinicians, we are so grateful to people like that physician and you, Jerry, and all those on the front lines, because it's nice to hear that there's such dedication out there. It's inspiring. And Cathie, how about you? What's the story of the week on your end?
Oh, of course, everybody knows I'm going to weave three stories of the week into one, because I'm so darn proud of our team and what they've accomplished. As you all know, we were one of the first in the country to do our drive-through Coumadin clinics, and watching how that has evolved up to this week of April 24th. We did our first ventilator hood, which was enormously successful as our ventilators get in shorter and shorter supply. As Jerry mentioned, we are sort of knee deep. Having that amazing expertise has been just phenomenal for our patients. And then we were very fortunate at one of our medical centers. We did the first 3 convalescent plasma protocols based off of the Mayo research project. So we did the first 3 in Illinois to 3 of our patients. So many of us don't know how we're going to help our patients with this disease process, but we were thrilled that one of our patients was well enough. He's got his plasma, I believe, on Monday, and was interviewed by one of our TV stations last night, well on his way to recovery. Was it the plasma? Was it not? Who knows? But I would encourage any of our COVID positive individuals out there, if you can find a plasma donation location, this is something you can do for as you now have the antibodies. Whether it will be a long-term solution, we don't know, but what a cool thing for at least 3 of our patients to be able to benefit from this emerging technology. So with that, I'd like to thank my MedAxiom colleagues for all their help on the listserv. We cannot do this day in and day out without all of your insight into helping us. So thank you very much.
Well, and thank you for heading us into the weekend on a positive note, both of you, with those great stories. As a reminder, we've got this webinar next week, next Tuesday, April 28th at 5 p.m. Eastern. Both Jerry and Cathie will be on that webinar about managing CV care reemergence, and you can register at medaxiom.com/COVID-19. Lots of resources there as well. Jerry and Cathie, I don't think of you two as the dynamic duo for nothing. So you were great. Thank you both for being on MedAxiom HeartTalk today.
Honored to do so, and reinforce Cathie's comments that this network is just unbelievable, and we need to keep pushing on together. So Cheryl, Candace, thank you guys so much for your expertise and sharing this with others.
Stay safe, everyone.
That's it for this weekly COVID-19 briefing. Don't forget to register for MedAxiom's 7th COVID-19 webinar next Tuesday, April 28th at 5 p.m. Eastern. Register at medaxiom.com/COVID-19, and that will be the panel discussion with Jerry moderating and Cathie as a panelist on preparing for post-COVID-19 patient care needs, Part 1. Also moderated by Lori Walsh, and other guests will include MedAxiom's Ginger Biesbrock and Nicole Knight. If you're enjoying these weekly COVID-19 briefings and MedAxiom HeartTalk, please refer your colleagues. They can find us and subscribe on Apple, Google, and all other podcast apps. It also helps us to have great reviews. So if you have a couple of minutes to review MedAxiom HeartTalk on your podcast app, we'd sure appreciate it. Or if you prefer to send feedback directly, shoot us an email. You can reach us at hearttalk@medaxiom.com.